and welcome to Ultrasound in Trauma, the FAST exam. This is Petra Duran, and I'll be taking you through this lecture today. The goal of this lecture is to be able to identify free fluid in the abdomen and the pericardium using ultrasound in the setting of trauma. You will also learn to distinguish between a pericardial effusion and pericardial tamponade. You will also learn to evaluate the patient for hemothorax and pneumothorax using the extended FAST exam. Let's start our discussion off today with a case. We have a 24-year-old guy who's brought into the trauma center after he was stabbed during an argument with his quote-unquote friend. He complains of pain in his belly only. He's hypotensive, tachycardic, tachypnic, and his room air sats are 98%. What is our next step? So what is a FAST exam? FAST stands for the Focused Assessment with Sonography in Trauma. The goal of the exam is to detect free fluid in the peritoneal cavity and in the pericardial cavity. Hemothorax and pneumothorax can also be identified by expanding the FAST into the chest cavity. The FAST exam has both pros and cons. It can be performed quickly, it's non-invasive, and it can be repeated easily if the clinical scenario should change. It is also highly specific for the need for a laparotomy. The big drawback of the FAST exam is that it's non-specific. Therefore, the fluid that you see in the abdomen could be blood or it could be ascites in a patient who has liver failure. It's also limited by body habitus and if there's any subcutaneous air. The FAST exam is indicated in chest or abdominal trauma to detect hemoperitoneum, pericardial effusions, and pleural effusions, or hemothorax. It is best used on hemodynamically unstable patients to determine if a trip to the OR is necessary. The use of the FAST exam has been extensively studied in blunt abdominal trauma. It has been shown to identify intraperitoneal bleeding caused by solid organ injury. But the use of the FAST exam in penetrating injury is somewhat controversial due to its low sensitivity for determining the need for laparotomy and its inability to detect bowel injury. However, some clinicians advocate its use in assessing for significant hemoperitoneum and in prioritizing management when multiple penetrating injuries are present. Bedside ultrasound may significantly decrease mortality in patients with penetrating cardiac injuries. Early detection of pericardial effusions can prevent cardiac tamponade in cases where a wound to the heart bleeds into the pericardium, not the chest cavity. This may occur when the pericardium seals itself after penetrating injury. Thus, all patients with penetrating chest injury should be screened for a potential pericardial effusion. If an effusion is present, cardiac injury is assumed until proven otherwise. The extended FAST exam can be used to detect hemothorax after penetrating injury and is actually more sensitive than the standard supine chest x-ray. Ultrasound can detect as little as 20 cc's of fluid in the chest. The FAST exam works to identify free fluid using the basic anatomy of the abdomen and pelvis. Fluid pools in very specific areas based on the tethering of the bowel and the intra-abdominal organs. This tethering channels fluid into specific areas around the solid organs of the abdomen. The amount of fluid in an area can further be maximized by positioning the patient to take advantage of this drainage system. Trendelenburg will increase fluid in the right and left upper quadrants, whereas reverse Trendelenburg increases fluid draining into the pelvis. To perform a FAST exam, you'll need an ultrasound machine with a low-frequency probe that will allow you to visualize deeper structures in the abdomen. Ideally, the ultrasound machine should be portable or at least maneuverable in a possibly crowded trauma bay. I have already alluded to the components of the FAST exam, but let's review them again. Right upper quadrant, left upper quadrant, cardiac, and suprapubic. The cardiac view may be obtained in the subxiphoid plane or in the peristernal long axis. The extended FAST, or EFAST, uses the traditional four views but then also looks into the chest cavity. So let's now go into each view in depth. The right upper quadrant is the most likely area to see free fluid in the abdomen. The probe is placed in a coronal plane with the probe indicator towards the patient's head at the mid-axillary line at the costal margin. Slide the probe along the mid-axillary line to find Morrison's pouch and to get around rib shadows. It's important to be able to see the entire kidney to ensure that you are not missing any fluid that may pool at the inferior pole. Whew, that was a mouthful. I have an easier way for you to find the correct position for your right upper quadrant view. If you draw an imaginary line from the xiphoid process down to the mid-axillary line and you place your probe right there, you should be right at the level of Morrison's pouch 99.9% of the time. As we look at the ultrasound image here, we can see this is that classic right upper quadrant view on ultrasound. So let's orient ourselves first. The patient's head is to the left side of the screen, and their feet are to the right side of the screen. The top of the screen is what lies closest to the probe, and the bottom of the screen is what's farthest away. This view encompasses the liver, the right kidney, and the diaphragm. Morrison's pouch lies in that hepatorenal interface, which is now visible as that crisp white line of Girota's fascia. This is a normal FAST exam picture of the right upper quadrant. It is important to angle the probe posteriorly when performing the upper quadrant views. Notice in this cross section that the IVC and the aorta are elevated more anteriorly on an island of the vertebral body, and that the kidney is posterior in the abdomen. Therefore, if you angle your probe anteriorly, you will visualize the liver, IVC, and aorta. If you angle the probe posteriorly, then you will see the liver and the kidney interface. So be sure to angle the beam to the bed for best visualization. So take a look at this video. You can see on the left side of the screen is the patient's head, the right side of the screen is the patient's feet, our liver is visualized here in the center, and then our kidney, and right in between them we see that black stripe of free fluid. This is a positive right. Here is another image of a positive right upper quadrant ultrasound. Notice the black stripe in between the liver and the kidney, which is Morrison's pouch, but also notice that the fluid extends superior to the liver and inferior to the liver. Remember that fluid can appear both above and below, not solely in Morrison's pouch. The left upper quadrant view is our next stop during the FAST exam. Just like in the right upper quadrant, the probe is placed in a coronal plane with the probe indicator towards the patient's head. Slide down to the posterior axillary line at the costal margin. It's important to remember that the left kidney lies more superior in the abdomen than the right. The left upper quadrant is always more difficult to obtain than the right due to the fact that the structures are usually under the rib cage. Consequently, you may need to angle or fan your probe to get in between the ribs to get that optimal view. The easy way to find the correct position for the left upper quadrant view is to note where you placed your probe in the right upper quadrant view. Draw an imaginary line straight across the patient's torso, and then slide your probe up one rib space. Your hand should now be against the bed, angling anteriorly due to the severely posterior position of the splenorenal interface. Now, if you're having difficulty getting your images due to the ribs, have the patient take a deep breath, if they're able, and that may actually inferiorly displace the diaphragm and the resultant organs so you get a better picture. Here is the classic left upper quadrant view. Recall again that the patient's head is to the left side of the screen and their feet are to the right. The top of the screen is closest to the probe and the bottom of the screen is what's farthest away. Note that that in this view, it should include the spleen, the left kidney, and the diaphragm. Notice that crisp hyperechoic or white line of Giroux fascia. This is a normal FAST exam picture of the left upper quadrant. Here is another view of the left upper quadrant. Again, orient yourself so that the patient's head is towards the left side of the screen and their feet are towards the right. We're seeing here our spleen and our kidney interface. What's really important to note is that we look at the inferior pole of the spleen, because fluid will often collect there prior to being in the splenorenal interface. So be sure to always slide down to interrogate that area when you're doing your left upper quadrant view. So here's an image of a positive left upper quadrant ultrasound. Notice the anechoic or black area superior and inferior to the spleen. Despite the free fluid around the spleen, there's actually very little fluid in the space between the spleen and the kidney. So always interrogate the superior and inferior poles of the spleen so as not to miss any small fluid collections. Now we'll move to the suprapubic or pelvic region of the FAST exam. For this portion of the exam, the probe is placed over the bladder, midline, and just superior to the pubic symphysis. The transverse or the longitudinal view may be obtained. To view the area in a transverse plane, place the probe with the probe indicator to the patient's right. To view the long axis or sagittal plane, place the probe indicator to the patient's head. It is usually easiest to view the pelvic area in a transverse plane first. So place the probe just above the pubic symphysis and angle to the patient's feet. It's important to realize that we are attempting to view the bladder behind the pubic symphysis. So angling the probe posterior to the bed and inferiorly towards the patient's feet will allow the beam to sneak behind the pubic bone to visualize the area underneath. So starting in the transverse plane, remember that our probe indicator is towards the patient's right. The left side of the screen is the patient's right. The right side of the screen is the patient's left. Here we can visualize the bladder as a fluid-filled anechoic rectangle or square. Notice that the uterus lies just beneath the bladder. Therefore, fluid should pool in the pouch of Douglas, which lies posterior to the uterus, before it extends into the vesicouterine space. Please note that the fluid contained within the bladder has very smooth edges, unlike free fluid, which would have very, very sharp ones. Now, if we rotate our probe 90 degrees so that the probe indicator is towards the patient's head, we have our long axis or sagittal view of the pelvis for the FAST exam. Remember that the patient's head is to the left side of the screen and their feet to the right. Notice that in the long axis plane, the bladder appears more triangular and the uterus appears pear-shaped. Fluid will be visible in the pouch of Douglas behind the uterus. Here is what a positive FAST exam picture of a transverse view of the pelvis looks like. Notice that the uterus appears to be floating in fluid, and that the pouch of Douglas is completely full of free fluid. You'll notice that the edges are very sharp and spiculated. That's the best way to tell if the fluid is contained or is free floating. Here is a video of a long axis view of the pelvis in a male. Notice the hypoechoic circular prostate visible to the right of the screen, just below the bladder. This video demonstrates how the prostate is not intraperitoneal, as you'll notice the hyperechoic white line of the peritoneal reflection just to the left of the prostate. Within the peritoneal cavity, though, there is copious free fluid with multiple bowel loops floating in it. Now that we've interrogated the upper quadrants and the pelvis, we'll turn our attention to the cardiac view. The heart may be imaged in several planes, but for the FAST exam, the subxiphoid approach is the most common. The parasternal long axis view can be used if the heart is not visible in the subxiphoid plane. We're going to look at each of these approaches in further detail shortly, but whichever view you choose, the goal is still the same. Identify cardiac activity and look for a pericardial effusion. If an effusion is present, then you want to demonstrate right ventricular collapse to make the diagnosis of pericardial tamponade. There are many factors that can affect which of the two cardiac views will be most successful. Much depends on the patient's body habitus and their clinical condition. Patients with severe abdominal pain may not tolerate the pressure needed to perform a subxiphoid view. Those patients who have enlarged abdomens due to pregnancy or morbid obesity can have a more difficult subxiphoid view to obtain due to the fact that their diaphragm is so high in their chest and subsequently their heart is so far away from the probe. On the other hand, patients with COPD have elongated lung fields and a low-lying diaphragm, which makes their heart much closer to that subxiphoid view. To achieve the subxiphoid view, place the probe in the patient's epigastrium with the probe indicator to the patient's right. The probe is then angled to the patient's left shoulder. An important tip to remember is the probe should almost be flat against the patient's abdomen in order to achieve the necessary angle to see the heart. I usually recommend holding the probe from the top and pressing down to achieve best results. Just remember we are imaging farther away from the probe than in the previous two views, so it's important to increase your depth settings on the machine in order to bring your heart into view. Increasing the depth in the subxiphoid view is essential. The default depth setting of 16 centimeters will not allow for complete viewing of the heart and the posterior pericardium. However, by increasing the depth of view to at least 21 centimeters, the heart will be centered on the screen and the pericardium will be visible. This is a schematic view of the subxiphoid plane. Notice the liver lies at the top of the image, corresponding to the structure closest to the probe. This makes sense when you recall that our probe is in position in the epigastrium. We're using the liver to displace the bowel and create a window so that we can view into the chest cavity. Since we're viewing the heart from underneath the diaphragm, the left side of the heart is farthest from the probe and we're at the bottom of the screen. Notice that this is a 4-chambered view of the heart. Here's an ultrasound image of the subxiphoid view. And just like the schematic we looked at, the liver lies closest to our probe and is at the top of the screen. The left side of the heart lies farthest from the probe and lies at the bottom of the screen. And the pericardium is outlined in white. The myocardium is gray and abuts the pericardium. It's important to note this relationship, as this is where we're going to be looking for effusions during our FAST exam. Here is the video of a normal subxiphoid view of the heart as part of the FAST exam. Again, notice that the liver is at the top of the screen and that the pericardium is at the bottom, along with that left side of the heart. If you're unable to obtain a subxiphoid view of the heart, then you may use a parasternal window. The probe is placed adjacent to the left side of the sternum at the nipple line. Since the heart lies along a diagonal plane within the chest, the probe should also be placed on a diagonal to achieve this long axis. Place the probe indicator to the patient's right shoulder. And depending on the exact lie of the heart, you may need to slide up or down a rib space to get the view. Here's a schematic of the parasternal long axis view. You'll notice that this view has only 3 chambers in it. the left side of the heart is visible as both the left atrium and the left ventricle, but on the right side, only the right ventricle is present. This is really important to note because this is what we're going to be looking at when we determine if pericardial tamponade is present. Here is the actual ultrasound image of a heart in the parasternal long axis. Note that in this view, the right ventricle is closest to the probe and the left side of the heart is farthest from us. And the aortic root is smack dab between the right ventricle and the left atrium. Here's a normal heart and a parasternal long axis view. You'll note that what's closest to the probe at the top of the screen is your right ventricle. It appears to be almost pie-shaped. At the bottom of the screen, outlined in white, is that posterior pericardium. Just anterior to that, you'll see the left ventricle and the left atrium, and then on top of the left atrium is the outflow tract. Here's a still image of the subxiphoid view of the heart. Notice that there's black fluid lying between the hyperechoic myocardium and the pericardium. This is a small pericardial effusion. Here is a video of a heart in a subxiphoid plane. You'll note that there is a black anechoic area surrounding the entire heart, which indicates a pericardial effusion. If a pericardial effusion is identified on your FAST exam, then it's important to note if tamponade is present as well. To rule out tamponade, we have to first look at the right ventricle in motion. Normally, the right ventricular free wall contracts symmetrically towards the middle. But with tamponade, the outer wall of the ventricle actually depresses in centrally. It always looks to me as if someone took their finger and they just pushed right down on the center of the wall. And it creates what appears to be the letter M instead of that curved outer wall. This picture is a wonderful example of pericardial tamponade in a still image. In this video of the heart, there is definitely a large pericardial effusion present. But look at the right ventricle at the top of the screen. Notice how the free wall of the right ventricle depresses with every heartbeat. The free wall looks like a trampoline with some guy just jumping on that outer wall, depressing it inward. This is tamponade. We have already discussed the 4 standard views of the FAST exam, and we'll now look at the additional views needed to perform an extended FAST exam, or an EFAST. The idea of the extended FAST is to briefly look for evidence of hemothorax and pneumothorax. I know this sounds daunting, but it actually doesn't add much to the exam that you're already performing. We have already talked about the upper quadrant views, and that's a critical component to the extended FAST. So while you're interrogating that right and left upper quadrant, you simply need to slide your probe a little more cranial to be able to evaluate the pleural space. You're also then going to be interrogating the chest for pneumothorax, which does require an additional view, so we'll discuss that in just a moment. So let's start our discussion of the EFAST by looking for fluid collections in the chest. While you're interrogating the upper quadrant views, simply slide the probe a little more cranial so that the focus is on the inferior lung fields. Fluid will pool in the dependent areas, so in a supine patient, one would expect that the fluid in the chest would pool posterior laterally. To look for a hemothorax or pleural fluid, we need to focus on the diaphragm and what lies just cranial to it. Normally, in the upper quadrants, we see the mirror image of the liver or spleen on the cranial side of the diaphragm. If this mirror image is absent, you will see black instead. That is fluid in the pleural space. In more severe cases, the fluid will actually surround the lung and it will appear to float within this fluid collection, appearing to be a sail fluttering in and out of view with inspiration. So let's look at this normal right upper quadrant view here. We see the liver and the kidney easily viewed. You'll notice the diaphragm to the left side of the screen, and if your depth is increased slightly, you will also notice the spine sign at the bottom of the screen. The spine sign is a hyperechoic vertebral body's shadowing that continues to the level of the diaphragm in a normal patient. On the cranial side of the diaphragm, you'll notice what appears to be liver, but this is just that mirror artifact created by the diaphragm. This mirror artifact is only seen in a normal lung, so if that mirror artifact is absent and the spine sign continues past the level of the diaphragm, then there's definitely fluid in the chest. Here's an image of the left upper quadrant with pleural fluid. Notice the lack of the mirror artifact on the cranial side of the diaphragm. You'll also see that black anechoic area, which indicates pleural fluid. Here's a video of the right upper quadrant with pleural fluid. Notice the lack of the mirror artifact on the cranial side of the diaphragm, and how the spine sign extends all the way along the bottom of the screen, well past the diaphragm. Using these two things together, the mirror artifact and the spine sign, you can confirm for yourself that there is definitely fluid in that chest cavity. Let's move on to pneumothorax now. Pneumothorax occurs in up to half of all trauma patients. Unfortunately, the standard supine chest x-ray will miss about 30% of those. Ultrasound, on the other hand, is very sensitive at detecting small and anterior pneumothoraces, with sensitivities equal to CAT scan. So the question is, why are we still doing chest x-ray as a standard protocol? To look for pneumothorax with ultrasound, you'll most likely need to change probes. You would want to use a high-frequency linear probe to give you the most detail so that you're not missing any of these traumatic pneumothoraces. The probe is placed on the anterior chest wall in the sagittal or long axis plane with the probe indicator towards the patient's head. We'll then slide down the anterior chest wall, examining each inner space as we go to rule out pneumothorax. Here's a normal lung picture on ultrasound where the probe indicator is to the patient's head. The ribs appear in cross-section as hyperechoic ovals with distal shadowing. The pleura appears as the hyperechoic line in between the two ribs. Some people have described this as a little frog on a lily pad, with the frog's eyes being each of the ribs and the pleura being his little froggy mouth. Do you see it? When we are evaluating someone for pneumothorax using ultrasound, we need to focus on the pleura, or our little froggy's mouth. The pleura should slide back and forth, glittering with each breath. Initially, this can be difficult to see as the slide can be somewhat subtle. So, if there's a question as to whether the lung is sliding or not, then you can turn to M mode, or motion mode, for further confirmation. However, if the lung does not slide, then a pneumothorax is present. Here's a side-by-side comparison of a normal lung on the left and a pneumothorax on the right. Look at the movement of that hyperechoic white pleural line. We are watching as the visceral and the parietal pleura slide against each other in that normal lung. Whereas the lack of slide seen in the pneumothorax is due to the fact that the lung is deflated, and therefore the pleural layers cannot slide against each other as they're not in contact anymore. Hopefully you can see the difference here between the pleural slide on the left and the stillness of the pneumothorax on the right. And yes, the video on the right is actually playing. If you're having difficulty seeing the difference in the previous slide, then M mode can further clarify matters. M mode is motion mode. When activated, a vertical line appears on the screen, and every point along that line is graphed over time. Just like in seismography, motion creates upward or downward deflections or a wave, whereas stillness creates a straight horizontal line. By placing your M-mode cursor on the pleura centered between two ribs, we can take a tracing of the movement of the pleura. A normal lung pleura will move and therefore create a tracing, which has classically been described as a sandy beach. A pneumothorax, on the other hand, will lack any motion and therefore create a straight line across the tracing, denoting the classic barcode sign. Now that we've discussed our EFAST in detail, let's get back to our trauma case. So a limited FAST exam was performed on our patient. He was noted to have a positive right upper quadrant view and a pericardial effusion with, you got it, tamponade. He was immediately taken to the OR and found to have a liver laceration which extended upward through the diaphragm, pericardium, and into the left ventricle. Luckily, this tract allowed for drainage of fluid coming from the heart and into the peritoneum, keeping him alive until it was repaired. So, in conclusion, there are a few things I'd like you to remember. Always angle your ultrasound beams toward the bed when you're scanning the upper quadrants. That way you're able to focus on the correct areas and not more anterior structures. Scan through the pelvis in both a long and transverse plane. That way you're not missing any free fluid that might be hiding out. And lastly, take note of your patient's body habitus so that you can optimize the cardiac view of your patient. I hope you've enjoyed this lecture on the extended FAST exam and may have actually learned something. Please feel free to contact me with any questions or concerns. Again, this is Petra Duran. Thank you for your attention.